Welcome to NatRevMD, a podcast where we share tips on optimizing medical billing and improving practice efficiency so you can have the business of your dreams. I'm your host, Dr. Heather Signorelli, founder of NatRevMD. Let's get started. Hey guys. All right. So to continue on with really understanding six-figure revenue streams that you are probably doing the work for already and may or may not already be billing for that. So today we're going to dive deep into a couple topics, start with kind of some of the behavioral health integration codes, but then also really look at care coordination and advanced primary care management. So lots to unpack here. It is going to be a meaty podcast, but we'll have a blog that we'll post with it as well so that you can go and check out the details there and let us know if you have any questions at info@natrevmd.com. All right. So obviously, you guys all know you guys are the front line for your patients, right? This includes mental and behavioral health needs, whether you're an OBGYN practice, primary care, or really many even other subspecialties, you do get pulled into behavioral health conversations. And so today we're going to talk about kind of the what and the how in terms of billing for this and how it compares to kind of some of the other CCM, TCM, RPM services, and then how there's a new 2026 broad codes that you can use that kind of lump together billing for all of those programs together, and then how you can do some add-on codes for behavioral health. So we're going to cover who qualifies, what to document, how to bill for it, especially kind of some rules around E&M codes, and really those exact steps to implement this into your practice. So even if you know nothing about this today, I'm hoping that you walk away with ways to, again, bring in revenue of stuff that you're already doing. All right. So first things first, we're going to talk basic kind of ways for you to think about behavioral health integration codes. And we're going to kind of call this the crawl. And then we're going to talk about the run approach when it comes to billing for some of this. So the crawl approach is really just focusing on the BHI codes, right? So there's behavioral health integration codes, which is that 99484. And again, this is not a new code. It's been around since 2018, but it is one way for you to bill. And then we'll talk about some of the newer codes in 2026. So think of this as kind of your on-ramp, right? It's what you can start with doing without hiring new staff as a way to integrate this, again, for services you're probably already providing. So who can bill for this? So physician, nurse practitioners, PAs, clinical nurse specialists, and certified nurse midwives. And so, who's doing the work? It's your existing clinical staff working under your direction, and they do not need to be specialized in behavioral health training. And so the work for this is about 20 minutes per month of non-face-to-face care management, which can include assessments, creating a care plan, coordinating treatment, all the things. And typically that national reimbursement's about $55 a month. So it's a good way to start. And then we'll kind of build upon that. So we'll talk about the run approach, which there's kind of a couple different ways to look at this. So we're going to talk about collaborative care models. COCM is the acronym. And this is more of this larger team-based approach that provides a much more intensive care and, of course, gets a higher level of reimbursement. So this is building upon behavioral health service team, so to speak. And you do need a specific kind of team in your pocket, right? So of course the billing practitioner, right? So they're going to be overseeing the entire process and the person kind of responsible from a billing perspective. Then you basically have a behavioral health care manager. And this is that core of the collaborative care model. And you do need to have, those individuals do need to have formal education, social work, nursing, psychology, et cetera. And they're kind of the ones doing the heavy lifting. Then you need to have a psychiatric consultation, somebody who is a psychiatrist or psychiatric NP who consults with your care manager. Typically weekly, they are reviewing caseloads. Crucially, this is that consultant that can be remote, so they don't have to be participating Medicare provider, and they don't have to be in your office, but somebody that person, the behavioral health care manager, is working with. All right. So the codes and the money. So for the initial month, it's a 99492. Again, all of this is in the blog, but we're just going to talk about it through the podcast. So $150 for the first 70 minutes of care manager time. And then you've got some codes for subsequent months. So that's the 99493, which is about $130 for your first 60 minutes. And then you've got some add-on codes, 99494 for additional 30 minutes. So a 100 patient collaborative care management program could be $150,000 annual opportunity. So real scalable business model within your practice. Again, 3 codes, that initial month, subsequent months, and then those add-on codes for additional 30 minutes on a per month basis. So building the system obviously does take some time. You do have to hire these individuals, even part-time, 1099. You don't have to have this full-time. You could identify those patients, see who's interested in enrolling, and we'll talk a little bit about identifying those patients here down below. So step 2 is the rules of engagement. So this is kind of that tactical ways to get this implemented into your practice and get paid for it. So key here is having an initiating visit. And this is your starting point. You can't just start billing for BHI. You really do need to have, a new patient who's identified. You must actually, see them live. So, and that's specific, especially if you haven't seen them within the last year. So things like an annual wellness visit, a welcome to Medicare visit, a regular or established patient E&M visit, all of those count. And then the visit establishes the patient relationship. You have to make sure you have that. You're the billing provider. You assess the patient, determine the BHI services are needed, and then, of course, document all of that. And then, of course, patient consent. So you must get a verbal consent from the patient before starting any BHI services. And then, of course, make sure that they know that there may be a cost sharing, a part where they may get a copay or a bill for this. And the consent must be documented in the medical record. So this is one of the best parts about the BHI program is that you don't have to have everything in person. There can be an element of telehealth used. So back to that general BHI code, that 99484. So again, that's that 20 minutes clinical staff time, almost can be done non-face-to-face, phone calls, chart reviews, etc. There's no requirement for the clinical staff to be available in person. Now, for that collaborative care management team, that behavioral health care manager must be available to provide face-to-face services. But the services themselves don't actually have to be face-to-face. They can be provided telehealth. And then, of course, the psychiatric consultant that you will need to have kind of weekly check-ins with can almost always be remote. So the place of service rule is that the code for that can be where you would normally provide face-to-face, even if that BHI service was actually delivered remotely. So great flexibility there. Obviously, you're going to want to document consent, like I talked about. You're going to document that initiating visit, talk about your assessment and the need for BHI, and then talk about that care plan, right? Create that care plan, update it, and then track the time as you check in with staff, review charts, et cetera, or have conversations with patients, and then also having those conversations with the care consultant, with the psychiatric consultant. So you can use the things like the PHQ-9 for depression, the GAD-7 for anxiety. So lots of options here to use those to kind of help document, need and so forth. Obviously, for the collaborative care management, you are going to document weekly systematic case review between the care manager and that psychiatric consultant. So some questions that we often get is, can you bill an office visit, so an E&M code with BHI code for the same patient? Yes, you can, but obviously you can't be double dipping work. So obviously if an E&M code is for the face-to-face encounter, the BHI code is for the 20 minutes of non-face-to-face care management work that happens throughout the rest of the month. So you can't count the time you spent in the E&M visit towards the 20-minute threshold, right? Makes sense. Other kind of critical things for you to know is, so BHI and chronic care management, you can bill these in the same month, but the time and effort obviously has to be 2 separate issues. So CCM could be 2 major chronic issues that you're dealing with that have nothing to do with the BHI. So you can obviously bill those together, but the BHI issue can't count as one of your CCM issues. You can't double dip there. Now, BHI and the collaborative care management stuff, for those 2 programs, you can't bill both of those in the same month. You have to choose one model per month. I think one of the big things is that billing errors are going to be a big issue. So making sure, I talk about this, that you're doing eligibility ahead of time, that you're checking eligibility, making sure insurance is active for these patients that you're seeing. So you guys know we have an eligibility billing verification guide. Link is down below. Head on over and check it out if eligibility errors are an issue. All right, so now we're going to talk about some of the new codes for 2026. Advanced primary care management, that's not new, but we're going to talk about some of the codes that you can use with advanced primary care management. All right, so what is APCM? So is this really a new way, shouldn't say new, but it is a way to get paid for care management that you're already doing. So instead of billing for chronic care management, PCM and TCM separately and tracking all of the time, APCM basically bundles them into a single monthly payment. So huge deal for practices who've been struggling with just the pain and administrative burden of care management. And so some of those main differences between kind of traditional care management and APCM. So let's talk APCM versus CCM. So advanced primary care management versus chronic care management. So with CCM, you're having to track every minute, whereas APCM, you don't. And this is a big positive thing. Patient eligibility is different between these two. So CCM typically is for those patients who have 2 or more chronic condition, whereas APCM can be for Medicare patients, even if they only have 1 or even no chronic conditions. So a little bit more flexibility there. And obviously, reimbursement goes along. So CCM has more complex tiered billing based on time, whereas APCM is more this simple bundled payment, 1 code, 1 payment per month. And we'll talk a little bit about reimbursement here in a minute. So now let's talk APCM versus transitional care management, again, TCM. So TCM, right, remember, is that 30-day service after patient's discharge, whereas APCM, ongoing monthly service. TCM is more reactive, post-discharge care, whereas APCM is trying to be more proactive, preventative care. All right, so APCM last by comparing it to RPM. So we've talked about remote patient monitoring, right? And so RPM is more for monitoring specific, like physiologic parameters. So whereas APCM is trying to be more comprehensive. RPM has separate codes for device setup, data transmission. We talked about this a couple weeks ago, monitoring time, et cetera, whereas APCM, again, is that single bundled code. So APCM, simpler, more flexible, and is trying to do a comprehensive way to get paid for care management. And you are kind of seeing this as the future of primary care. Now let's compare that collaborative care management versus APCM. So this is kind of a common question that we get. So collaborative care management is about the care model. It's about the humans you have to pull together in order to deliver specific behavioral health services. So it is a specific team-based approach, whereas the advanced primary care management program is actually kind of the payment model, right? How do you get paid for it? So think of it like this. Collaborative care management is what you do, and then the APCM is actually the how you get paid for it. So this is what's changed in 2026. You can do both and get paid for both for the same patient in the same month. And that's because of the new G codes that came down, and we'll talk about those. So we've talked about a lot of different codes, a lot of different models. So we're going to talk a little bit about head-to-head and see which one comes out on top in terms of revenue. So RPM, remote patient monitoring, is that $50 to $95 a month. PCM can be $66 to $116 a month. Again, all of this is just, approximate numbers. CM alone, which is that GO557, is like mid-50s per month, but no time tracking. All right, so remember APCM alone, that GO557 is about $54 a month, but there's no time tracking. Whereas that standalone collaborative care management 99 is about $130 a month, but requires dedicated team, 60 minutes of time tracking. So kind of some differences there. Again, the APCM alone may have lower reimbursement, but again, may be easier to implement. Because remember that collaborative care management requires that behavioral health, manager person plus that psychiatric consultation. So now we know in 2026, they added those G codes for the behavioral health integration, and those can go along with your advanced primary care management program. The add-on codes are GO557, GO569, and that plus the APCM codes can be almost $180 a month. So obviously, huge win here if you can work with patients who need this service and document a clinical need. So I do think this is a big win, and we'll do a blog as well as a document that you guys can download around all of this. A lot of this is on the CMS website, but we'll try and boil it down for you guys in a simple how-to guide. So obviously, if you've got 500 patients who qualify for APCM plus behavioral health integration, we're talking, $80,000, $90,000 a month. This could be an additional, 7 figures for your practice. Obviously, if you're just doing the collaborative care management, let's say that's $130 a month. That's just shy of $800,000 a month, but you have to hire all those people. So difference with the APCM plus the behavioral health integration, so using both of those together for those patients is certainly a winner here. So if you have a primary care practice, again, even OBGYN, that's serious revenue that you could be bringing into your practice. One question we get is, say you had patients with APCM alone, right? Not with the behavioral health codes. It would be a lower revenue compared to the collaborative care management programs. So obviously this is kind of a tiered approach. So standalone APCM is going to reimburse less than that. But again, the CCO, the collaborative care management, is a lot more involved. So it makes sense. The key here is really that APCM plus the behavioral health codes. That's going to be the clear. So one thing to think about is, okay, so say you're doing CCM or TCM or RPM. So you're doing one of those and you're doing that today. Why would you choose those versus this more comprehensive APCM? And I would say that it's really probably about the number of patients you have. So if you only have a handful of patients who qualify for care management, the administrative burden of time tracking may be manageable, right? So you're fine. You do get a little bit higher reimbursement rates for certain individual services that may be more profitable. But if you have a larger patient population who maybe doesn't always meet CCM or TCM guidelines or RPM needs, and you maybe have patients who do qualify for just one specific condition, then being able to do APCM for those patients would at least capture some of that revenue, whereas they may not qualify for some of those more advanced reimbursements. So again, you could get paid more with the CCM or TCM or RPM, but again, you may not have patients who qualify, or if you have a really large practice, you may not want to deal with the administrative burden of tracking all the time for all of that. So you may say, okay, I'm going to scrap that, do higher volume and do the APCM and just make it simpler. So again, there are pros and cons to this. For each of these, there's not a really right or wrong way to do it. But think of APCM as a way to choose if you have a large number of eligible patients, you don't want the administrative burden of tracking time, and you have a large patient population. It's an easy way to provide comprehensive integrated care, but you get a bundled payment. So it's a little bit easier to manage. Whereas for CCM, RPM, TCM, there's much more nuances around patients that qualify for each of those and how to track time and how to bill for each of those, which gets a little bit tricky for practices, especially as you grow. Again, you could even do both, right? You could do the advanced primary care management for patients who don't qualify for the others, and you could do a hybrid. All right, so let's talk about implementation of APCM in your practice. So very similar, you're going to be identifying eligible patients, right? So in this case, we're talking about Medicare patients who may be eligible because, again, even those with just one or no chronic conditions could benefit. And just like with BHI, you need to make sure you have a consent, verbal or written, from the patient. You have to document that. Make sure that you've informed them of cost sharing and that they may get a bill for that, and that you have to make sure that only one provider can bill for this. With a lot of these services, right, only one can be the one who's billing for these types of services. So you want to make sure that they're aware of that. So if you have somebody else that could be billing for that for the patient, you'll want to, duke out who's going to be the one to take that on. Obviously, conduct initiating visits. Again, that can be a number of different visits that qualify, just like with BHI. And then you'll want to be able to put a system in place to provide the required APM services. So this includes things like 24 access, comprehensive care management, care coordination, and then, of course, choosing the right G code based on the number of chronic conditions. So 0 to 1 chronic conditions is at GO 556, which is, $16 a month, but again, adds up. Whereas at GO 557 is at mid-50s per month, $54 per month. That's 2 chronic conditions. And then the GO 558, which is those qualified Medicare beneficiaries with 2 or more conditions. And so these are the 3 APCM codes. You're going to want to choose the right one that makes sense for your patients. Now, remember that we've got those BHI add-on codes. Again, that's really where the compound revenue comes. And this is for 2026, these new codes. So this is the BHI services that can be added on top of your APCM codes. So this is the GO 568, which is for that initial collaborative care management, the GO 569, which is that subsequent month, and the GO 5, which is the add-on for general BHI. So what this means for your practice, right? So before 2026, you kind of had to choose between billing for APCM or BHI separately. Starting in 26, you can bill those together, which again is really helpful for those patients who have chronic conditions, but you also have that behavioral health need. All right, so I know a lot of information here. Bottom line is, if you aren't already doing one of these programs, please let's take a look and do this. APCM may be an easy way, not a lot of tracking for you to kind of dip your toe into it. If you're seeing patients who need behavioral health services, you can do those BHI services without having to have this entire team. Obviously, your CCM, your TCM, your RPM, that alphabet soup of kind of this chronic care management, transitional management, remote patient monitoring we've talked about, that's another bucket. And then kind of a higher bucket where you're really having to look at the team that you have for behavioral health is that collaborative care model. So kind of a couple different pathways for you guys to think about adding revenue to your practice this year. Again, these are really great ways for work you're already doing for you to get paid. As always, if you guys are enjoying the podcast, we'd love for you to share this with others, and it helps us impact other practices' lives so that they can increase revenue as they need. Links down below for a couple of the recent guides we've put out, and we'll also be setting up a guide to send out for this as well. So if you haven't gotten onto our email address list, head on over to natrevmd.com and subscribe so that you can get emails, and we can share the playbook with regards to all of that we talked about today. Thanks so much.